So today I'm going to be talking about the erythrocyte sedimentation rate, but for ophthalmologists. It is the rate in millimeters per hour of the sedimentation of the erythrocyte. So how fast do these red blood cells sediment in a tube over an hour in millimeters? It's a very simple test. It's from the 1800s, in fact, because it's not very technical. You look at the tube, you look at the tube again. You measure how much the sedimentation rate was. And the thing that prevents red cells from sedimenting, the reason your sed rate is normal, presumably, and is only 2 millimeters per hour, and a patient with giant cell arteritis sed rate is 100 millimeters per hour, the reason that difference occurs is because the red cells actually have a charge. And a potential is generated by that charge that keeps the red cells apart because like charges repel. And so that negative potential is called the zeta potential. That zeta potential is created by sialic acid residues on the surface of the red cell membrane that keep the red cells apart. And we need that because when we're passing through the capillary bed, we really have to have small enough single file to get the red cells to pass through there one at a time. And we really have to have them spaced out. We really can't have them all clumping together. So when you have a sedimentation rate that is increased, that means something, you don't know what, is decreasing the zeta potential and allowing the red cells to collect together. And when they collect together, they form this kind of stack of coins, which is the rouleau formation. So when that stack of coins occurs, of course that whole column is going to fall to the bottom, and that is what is the increased sedimentation rate. And the reason you need to know this in ophthalmology is it's not just about giant cell arteritis. So if you have inflammation of any kind, acute phase reactants are going to be released. For example, C-reactive protein, but also the platelet count. Those proteins, in response to any kind of disorder, inflammatory, infectious, and neoplastic malignancy, will block the charge. The red cells will aggregate, the rouleau formation will occur, and your sedimentation rate will go up. You should know that the sedimentation rate goes up with just age, because there's all sorts of proteins that are building up in your bloodstream as you get older. And so the empiric formula that we use for sedimentation rate is age plus 10 divided by 2 for women, and for men we just age divided by 2. So the normal sedimentation rate is age and gender dependent. These are just empiric formulas. If you can't remember any single number, 40 is kind of like too high for an older patient. And so we're relying upon the sedimentation rate to tell us that we have something wrong with us. And the reason it's important in ophthalmology is any elderly patient who has any neuro-ophthalmic symptom, you want to consider doing a sedimentation rate. It doesn't tell you what's wrong with the person, but it tells you something is wrong with the person. And that something could be giant cell arteritis. You also need to know that the sedimentation rate is not specific. If it's elevated, it might be renal failure from those proteins glomming onto the red cell membrane. It might be diabetes with sugar glomming onto the red cell membrane. It could be malignancy, it could be infection, inflammation. You don't know what is causing this elevated sed rate. And so you have to be thinking about other conditions. Neoplastic conditions like multiple myeloma often raise the sedimentation rate. So a sed rate by itself does not mean you have giant cell. And the reverse. You could have a totally normal sedimentation rate and still have giant cell arteritis because it requires the systemic inflammatory response and the reduction in the zeta potential. That might not occur if the disease is only right here. So an ophthalmologist needs to know about the rate of sedimentation of erythrocytes. It's usually a low number. It's age and gender specific. The higher the number, the more worrisome it is. It tells you something is wrong, but not what is wrong. You should be thinking about giant cell arteritis and be doing it in every patient who's elderly, who's got vision loss or double vision or amaurosis fugax or whatever they have. You're going to order the other acute phase reactants, the C-reactive protein, and the platelet count to help make a clinical decision about whether this sed rate is real or not. and need to know a little bit about rouleau and the zeta potential in ophthalmology.